All right, we are going to kick off the last session of this meeting, and that is fertility preservation in the non-oncological populations. If you have not removed your poster, you need to do so before 2 p.m. And our first talk is on fertility preservation for patients at risk for primary ovarian insufficiency by Veronica Gomez-Lobo. She is an OBGYN who specializes in pediatric and adolescent gynecology at the NICHD. Thank you, and Dr. Gomez-Lobo.
Yeah, I want to thank everyone for sticking it out for the last session of the day. And I also really wanted to thank you for inviting me because I'm really excited to start showing some of our results at the NIH. So everybody knows this paper now. It's been quoted multiple times at this meeting. So in 2019, in December, the ASRM came out with a statement that ovarian tissue banking is no longer considered experimental. But the key word to this is the word gonadotoxic. So I think a lot of us think of oncologic versus non-oncologic. I think gonadotoxic versus non-gonadotoxic. And so people really started thinking, well, if this works for people who are going to receive gonadotoxic therapy in conditions associated with accelerated follicle loss, can cryopreservation allow the girls to stop the clock on follicle loss and allow them to thaw the functioning tissue when they're ready to have children? And we're not the only people who have thought this. This is pretty old data out of Sweden, and in Sweden they have a national registry. The Europeans are way ahead of us for everything, and as you can see, they've been doing fertility preservation and OTC for Turner syndrome, Galactosemia, and POI, and those are exactly the populations we chose. So we have a protocol, it's protocol 106, which is called gonadal, and we changed it from ovarian to the gonadal, tissue freezing for fertility preservation in girls, and we changed that to individuals, at risk for ovarian dysfunction and primary ovarian insufficiency. And our first aim was just to see if there were gametes in that tissue, but our secondary objective was to really elucidate some possible mechanisms of follicle loss in some of these individuals. And then in the future, we hope to do some follicle activators and inhibitors on this tissue. And as I mentioned yesterday, in 2023, we actually modified this to include individuals with Turner syndrome with Y, as well as individuals with DSD. So this is, I wanted to mention something about the NIH. Many of you guys know the NIH as the people who fund your research, but the NIH has what's called an intramural. This is the campus, and it has an intramural program. So this is the clinical center, which is the hospital at the NIH. It's a really strange place. It, for example, doesn't have an emergency room. You have to go through security to get there, but we have a full hospital there. Every patient who's seen at the NIH has to be on a protocol, so you can't see anybody at the NIH unless you're on a protocol. But the beauty of the NIH is that for those who are from the US, your tax dollars are paying for this, so all care is free. And not just that, for this protocol, we can fly the child and the parent, we can keep them in-house, we can do the surgery for free, we can freeze the tissue for free, and we actually pay for the first year of storage. So those are the benefits of your tax dollars. So let me start with Turner syndrome. I want to give you a little bit of background and sort of what our results are. So as you all know, Turner syndrome is a condition in which there's a chromosomal disorder in which one of the cell lines may be missing an X chromosome or have an abnormal X chromosome. And it's one of the more common conditions that are associated with follicle loss, 1 in 2,500 assigned female. And it's associated with all these other clinical issues, but delayed pubertal development and POI is one of them. And it looks like there's this is embryo research that was done where they did tunnel staining on ovaries from embryos that were 46XX and then 4 Turner's ovaries, and they found a significantly higher rate of apoptosis of the oocytes with tunnel positive staining. Now, this is based on 4 cases, so I think it's a little bit difficult to extrapolate and really understand what's going on all the time. And we know that 30 to 50% of girls with Turner syndrome will go through puberty. Spontaneous menarche happens anywhere from 14 to 20%, and then spontaneous pregnancy around 5%. And I have all the references there. I do want to make a quick point about aortic dissection because I think right now ASRM has a pretty strong stand against helping girls with Turner syndrome to become pregnant. We have a multidisciplinary pediatric Turner's clinic at Children's National, and our pediatric cardiologist really feels that this is going to be less of a problem in the future as these girls are treated with better antihypertensive management. The other thing is the French have a pretty large experience that they've published with almost 300 pregnancies in Turner's patients. They do sequential aortic root ultrasounds during pregnancy, and they had 0 aortic dissection. So I think in the future, this is going to be much more less of a dangerous situation. So, you know, everybody worries, will the baby have a very high chance of having Turner's? And here's some work showing that the follicles, the granulosa cells seem to be 45x, but the oocytes usually has the normal complement, and that's why we don't see a very high rate of monosomy in the offsprings. And then the other issue that comes up is, well, if they're monosomic, those don't have any hope, and really peripheral blood doesn't mean anything. And here's a study that showed that in peripheral blood, 45x, the ovary actually had mosaicism. And so in our protocol, we're now doing buccal swabs and urine to see if we can correlate those karyotypes that we find with what's in the ovary. So I think if somebody with Turner syndrome goes through puberty, I think they can have oocyte cryopreservation or embryo cryopreservation. I think we've had a lot of discussion about, you know, the risks of OTC and should we be doing oocyte cryopreservation or OTC, and I won't delve too deeply into that with this population. And, you know, just to give you an example, somebody tried this on a 7-year-old. Now I'm going to quote Dr. Maverick here and say, well, those eggs are crap based on the bell curve. But so I think we need to be careful. Just because you get oocytes doesn't mean they're going to work well. But somebody did this on a prepubertal Turner's child. But, you know, there's a lot of literature with these small case series, so I do quote one of the more recent case series of women with Turner syndrome who had stimulation and oocyte cryopreservation. In the first paper that I quote here, average number of oocytes was 9 at first stimulation, even in low AMH, and they found that in their group, it was similar to non-Turner syndrome women. However, there's a systematic review that came out just this summer in Human Reproduction that really showed that there is difficulty in stimulating these girls with multiple cycles needed to obtain 10 oocytes. And the things that correlated with better outcomes, it's a no-brainer, right? Low FSH, high AMH, and a higher percentage of 46XX cells was associated with more cryopreserved oocytes in the first cycle. So what about OTC? And there's a lot of papers out there. There was a Delphi study of providers thinking about OTC for Turner syndrome. There's been a lot of opinion pieces. I put this normogram from Kutluk Oktay, which is widely quoted by the Turner syndrome patients, which is in families, which makes me really nervous because you may not be able to read this, but in prepubertal children, he basically said if their AMH is less than 2 nanograms per milliliter, you should offer OTC. And this is where we have to discuss AMH in children. You know, normal AMH in children is often less than 2. We know that AMH is made by growing follicles and not by primordial follicles. And we tend to think that growing follicles are a reflection of the primordial follicle pool, but I'm not sure it truly is. And there's a paper here looking at ovarian tissue in young women where the average age was 28%, and the AMH was not correlating at all with follicle density. and I'm going to show you some work from our lab. So we used the NICHD Oncofertility ovarian tissue image bank. So for those of you who don't know, all the slides that were sent to Northwestern through the Oncofertility Consortium were sent to us. We scanned them into a cloud-based Halo database, and then we added our slides from Children's National, our slides from NIH, and then slides from Pittsburgh. So anybody who wants to share slides with us, I think this is really valuable, and this is the type of research we can do. So Serena Hanfling is a medical student who was here yesterday with her poster, and she looked at those who were 0 to 24-year-olds and had an AMH value. And we included cancer, hemoglobinopathies, and genetic and autoimmune conditions, but we excluded things that would be associated with a low AMH, such as Turner syndrome, galactosemia, and variations of sex traits. Those can have a high AMH actually too, if there's testicular tissue. So she had 55 patients. She looked at least at 3 slides from each patient. So she looked at 165, and this was before artificial intelligence machine counting is fully functional. So she actually counted every single one of these, and she classified the follicles based on the NICHD nomenclature that I showed you guys on Monday evening. And AMH did not correlate with primordial nor growing follicles. So it wasn't just the primordial. It didn't correlate at all with the growing follicles either. So I'm really nervous about saying that a cutoff AMH value should be used to advise patients about OTC. So the Europeans are way ahead of us, as I said. This is data out of, I think Denmark, don't quote me on that. 93 girls underwent unilateral oophorectomy who had Turner syndrome. Now, what's interesting is they had girls who were 2 to 18. So if you have a teenager who went through puberty and is having periods, they're probably going to have follicles. So I think that kind of skews the data a little bit. But the favorable predictive markers for the presence of follicles was either a 46XX cell line, spontaneous onset of puberty, which makes sense, and a combination of measurable AMH and normal FSH. The problem is, if we are thinking that these patients have accelerated follicle loss, are we going to wait till that age before we collect the tissue? Shouldn't we be collecting the tissue as early as possible? So our protocol actually only goes up to age 12. And this is our data from NICHD. So we've done 13 patients. The ones in gray are actually Turners with Y. So we can exclude these, I think, but there have been reported pregnancies in people with Turners and Y, so we are allowing that to be collected. I think what's really interesting is the dark blue are the ones that had follicles, and they all had detectable AMH. It's low, but it's detectable. All the ones with undetectable AMH had no follicles, except for this one in light blue that had 2 follicles. So I'm not sure whether we should even count that. That's why I put it in light blue. But I think essentially what I think we're seeing is that if there is a detectable AMH, there's some hope that there's follicles there. For classic galactosemia, it's a little bit of a different situation. It's a rare condition. It's an inborn error of galactose metabolism. It's detected through newborn screening. Babies used to die from liver failure and renal failure until we had this as newborn screening and the special diet is instituted. And the children grow and do pretty well. They have some neurodevelopmental impairment, not that different from Turner syndrome, and these kids are doing pretty well. Most of them, but primary ovarian insufficiency is like greater than 80% of these women, and it doesn't seem to be related to their control, their dietary control, or when the diet was instituted. But just like with Turner syndrome, spontaneous menstruation happens in about 45%, so a higher rate of spontaneous menstruation, and there may be a little bit of a delayed puberty, but what's really interesting is these patients have a higher pregnancy rate, even when they have POI, than patients with POI usually do. So this Fertility and Sterility paper from 2017, 21 patients, 9 conceived spontaneously. It took them longer. It took them several years, but they did conceive. So a lot of unknowns. So these are all the papers on ovarian tissue and galactosemia. This is all there is in the world literature. There is one paper I found out about by Levi, which was on a baby that showed abundant follicles. But if I ordered these papers by age, so it goes from youngest to oldest, and so you can see that the younger kids have follicles, the older patients don't have follicles. So there definitely appears to be normal numbers of follicle when they're very little. So this is a case which may be different than Turner syndrome, where they're truly born with normal numbers of follicles that then is accelerated loss. And this is our data from our galactosemia cohort. So we've done 7 patients. We have one next week. I think what's really interesting is that this is very, very different from a Turner syndrome. All of them had very low AMH or even undetectable AMH, and then all of them had follicles. And you can see this patient here had undetectable AMH, but she had the most follicles of anyone else. So I think that AMH really does not correlate with follicle numbers in this cohort. And then this is Taylor Badger. She's a 4th-year medical student who's maybe applying to some of your residencies right now. She was fantastic. And she took our NICHD follicle classification system and then classified the follicles. And when we first looked at this, what was really interesting is we saw lots of primordial cells, but almost no primary, transitional primary, multi-layer, multi-oocytic, which we do see in children normally, and almost no antral. So we thought, well, maybe this is a problem of activation. And we compared this to our oncologic patients. We've been using our sarcoma patients as our controls because we figure that's not a systemic illness. I may be very flawed. There may be systemic effects, but we tried to pick those patients. The follicle density was clearly decreased between our galactosemia and our controls. The growing follicles were no different, but there was a lot more normal morphology in our controls. So something's going on in galactosemia, and this is what I wanted to show you, the kind of things that we can do with tissue, which is why I'm advocating for us to do tissue research and not just sit on our butts and say this is a done deal. So Raghu, who's here, is our staff scientist, and he did single nucleus transcriptomic of ovaries from galactosemia patients and from control patients. You can see the UMAP here, and he was able to figure out which clusters, which cells these clusters represented based on the expression of gene markers. So I think the granulosa cells are, I can't read this, but the granulosa cells and the oocytes could be picked up separately. And then he identified the granulosa cell cluster here based on these markers, and then compared expression in the granulosa cells between the galactosemia patients versus the controls, and was able to show functionally enriched pathways. So ovarian infertility pathway, the PI3K AKT signaling pathway, primary ovarian insufficiency, focal adhesion pathway, ovarian steroid biosynthesis, and estrogen metabolism pathways were increased in the GALT genes. And this is what Visium data looks like. So this is spatial genomics, and you can see the H&E stain tissue here, and this is our Visium. Unfortunately, the Visium doesn't have enough, it's not deep enough to be able to separate the granulosa cells from the ovaries, but we were able to identify oocytes here and granulosa cells. And this is the cluster of follicles. And when we compared galactosemia to controls, we found some other pathways that were enriched in our galactosemia patients here, but some pathways were enriched both in the single nucleus and the Visium data. So this is, I don't mean to go so deeply into this, but I want you guys to get the sense of what we can do. And this is the PAKT expression of primordial cells, and this signaling is essential for early follicular development and crucial for survival and activation of growth of primordial follicles, and you can see a big difference between our controls and our galactosemia. So here our controls are staining for this, and they're not in the galactosemia. And then caspase 9 is a well-known initiator caspase, which triggers intrinsic apoptosis, and you can definitely see more apoptosis, more caspase-9 in our galactosemia patients. Why this is happening, we still don't know. I think Raghu is speculating that this is really local toxicity from the precursors of the GALT gene. And these were our conclusions that single nucleus RNA sequencing and spatial analysis revealed genes related to PI3K, AKT signaling, ovarian infertility, apoptotic pathway, and ER stress signaling that's enriched in galactosemia patients. And this may, I think our next step is just figuring out why this is happening and how this is being triggered with in vivo and in vitro models. So now I'm going to switch back to what we're doing clinically. So the third group of patients who are receiving this OTC are teenagers with POI. So as you know, POI in adolescence is pretty rare. It's about 1 in 10,000, not related to cancer therapy. And some of these patients conceive spontaneously. I know Dr. Larry Nelson always quoted 5 to 10%, I think it's lower than that. And the mechanism of POI can be from follicular dysfunction or follicle depletion. Now, we're not going to do all comers. This is probably fairly far-fetched, so our protocol includes teenagers who at least went through menarche and had a period within the last 2 years. But what made us think of this is some of this Japanese data that showed that if you took out ovarian tissue and activated and placed it back in the patient, they were able to achieve some pregnancies. The idea being that there may be some follicles left. So this is our data for autoimmune cases. So we've had 2 autoimmune cases. Both of them had periods within a year from when they underwent OTC. They were both diagnosed very quickly. Both of them had normal appearing ovaries. Neither one of them had any follicles, and both had undetectable AMH. And then so there's all these other rare conditions. As we identify more genes that are associated with POI, there's all these other rare conditions that then we're thinking, oh, should we be offering OTC to these patients? So this is a patient with BPES. I won't pronounce the name, what it stands for. It's a pathogenic FOXL2 variant mutation. And it's interesting, I went through the literature to look back on it. This is super rare. There's 2 types. There's one type that's associated with POI, and the other type is not. But they're only distinguished by the POI. It's a clinical distinction, so we still don't know how to distinguish which ones are going to get POI and which ones are not. But this child tried to be stimulated, and they were not able to retrieve any oocytes, so we performed an OTC, and she had primordial cell follicles that were noted. So it's just an example of what may come up more for this type of case. So there's huge knowledge gaps here, huge. What's the quality of these follicles and stroma? What is the mechanism of follicle dysfunction and follicle loss? And are there options for possible prevention? What if the AMH is undetectable? Does that change the outcome? Can OTC arrest follicle loss? Are we just taking out this ovary and all these follicles are dying anyways? Does laparoscopically removing an ovary significantly alter the time of POI? And I know Jen Levine mentioned yesterday, and there was a lot of discussion around this, and I would contend that if you remove an ovary at the point of the curve where the follicle numbers are being lost slowly, you probably don't impact it. But after age 35, we know we lose follicles rapidly, and if you're removing an ovary then, you may be impacting the outcome significantly. And so these patients already have reduced follicle numbers. Are we making things worse, or is it sort of the equivalent of somebody who's losing follicles more rapidly already due to age? Is the follicle loss that occurs after transplantation increased in these conditions? So until we figure out how to manage follicle loss in these conditions, is it going to be worthless to transplant this tissue back? And then I put this separate at the bottom because this is something that the families ask me a lot about. I'm actually talking to the European Galactosemia Society on Saturday, and they told me, please talk about this issue. At what age should the OTC be performed? And I have just a couple more thoughts. So one of the interesting things is, the streak gonads, I think, are not going to have any follicles. And I have this hypothesis that streak gonads form in utero. versus we have some ovaries that look completely normal but have no follicles. That's sort of recent loss of follicles, right? So is the appearance predictive of when follicle loss occurred in utero versus after birth? And this makes a difference because we're not saving these ovaries while they're in utero, but we can after birth, right? Or doing OTC. And then is pre-op imaging helpful? And so we've been doing transabdominal ultrasound in these girls in the operating room with full bladders, and it has not been helpful. So now we've started MRIs to see if we can correlate the images on MRI with what we see in the OR, so that in the future we can predict who is going to have a streak gonad where it's really not worth doing this. And so I want to leave you with this last concept, which I wrote this with another medical student and one of the bioethics people at the NIH. And you know, we really considered, should we be offering this as like innovative care? So this is new, but we're offering it as care, or should we be doing this under research protocols? And by research protocols, I don't mean an IRB that protects you, where you can do this and then you send a tissue and you don't learn anything from it. I mean learning something from this. And based on sort of ethical principles, I won't go through the whole thing, we really think this type of that any OTC on these populations should be done under research protocol. We have to learn from this. We can't just do this randomly. And we need to figure out who's gonna benefit, who's not gonna benefit, and really, or can we predict why this is happening and maybe have an impact on these patients. So that's my plea. My plea is do research, research, research. So this is my team, the pediatric gynecologist at Children's and at NIH. NIH has this wonderful program where medical students can spend a year between their third and fourth year. They actually live on the campus. And then we have post-baccalaureate students who come between college and med school. And then our fellows and my labs. Thank you very much.
We have a few minutes for questions. I'll ask one. So AMH, I agree with you, a single value is not useful. Do you feel that trending this in patient population is useful at all either?
I don't know. I mean, you know as an REI that some people's AMH is down here, and then it's here, and then it's here. That's why we need data. So, yeah. Dr. Silber.
I think that it's really important to try to decide or distinguish whether there's an accelerated loss of follicles in Turner's patients, or whether they just start out with less follicles, because all little girls and all women are going to lose at least 1,000 follicles or more every month anyway. And we know that the only reason that the Turner syndrome patients are alive is because they have to all be mosaics. It's just, it takes very, very few cells to be XX in the body to do the housekeeping functions that are missing in the Turner syndrome patients otherwise. And so maybe that's just a matter of whether the ovary happens to have enough XX cells. Peake's paper demonstrated that, it's just a normal follicular loss that everyone has. And they're just starting out with less to start with. I don't know what your thoughts are on that, because you obviously have a lot of experience. You may have a thought on that.
Well, you have more experience than I do with Turner syndrome, and I almost quoted you that if you're truly a mosaic monosomy, you can't be alive. I don't know. This is why I think we need to have research, and I think, you know, that's one of the things. Does buccal swab correlate with ovary better than peripheral blood? I don't know. It's not that easy to do the FISH experimentally. We're trying to do the FISH on these tissues now and these cells now.
Thank you very much. It's good,
Thank you.
Good, really good talk.
Hi. For the patients who have to use hormone therapy in order to have their uterus grow, to my knowledge, there's no like size cutoffs in the literature as to what would be like how those correlate to pregnancy outcomes, but how do you counsel patients?
Yeah, so that's a really good question. So the issue of uterine growth with puberty induction estrogen has not been really well answered. I know Tazim, who used to work with us, Dalit McElroy, who's in Kansas, tried to do a study to look at uterine growth with different formulations of estrogen, like was transdermal better than oral. But clearly some of these patients have uterine factor infertility in addition to their POI. But in general, the uterus does grow pretty well with estrogen. The issue is which estrogen should we be giving and how. That it may be that transdermal is better. That's my personal bias, but I have zero data to support that.
Hi, Veronica. Thanks so much for doing this research in these 3 populations. So do you have a parting line for all of us as to who do you want us to send you and in what circumstances? And so obviously I think none of us want to miss a critical boat, but I don't know that your team wants to be flooded with a bunch of patients where, we're offering false hope and you're not going to get anything. If you could just quickly summarize that for each of these populations. Yeah. And then is that information easily available on your website
It's
too?
really easy available. If you email us, we'll send you flyers, but it's also available in clinicaltrials.org. And if you Google my name with the NIH, these protocols come up. So we are doing 4 to 12 for Galactosemia and Turner syndrome. We want to go lower than 4, but because NIH is a weird hospital, they're really worried about us doing really young kids. I purposely chose 12 because I felt like at 12, most girls have entered puberty, and if they're in POI, I think it's really hopeless. Now, if they go through puberty and get a period and they try to stimulate and they can't have, they don't retrieve anything, then at that point they have DOR and they qualify. For the adolescents, if they went through puberty, got periods, and they've had a period within the last 2 years, and now they're diagnosed with POI, we can do them, and the upper limit is 21. The other thing is you can send patients with POI, Jackie Maher has really a great interest in that, and we can send them to NHGRI for whole genome sequencing, so we can do other things with these patients. So you will not overwhelm us. And we're pretty careful with our counseling. We do an hour Zoom just to explain how this is really experimental, probably nothing, go through the whole thing.
But I didn't hear like a karyotype or a lab type.
No, so I've been very agnostic so far, and this is the reason, is because we don't have data. So until we have the data, and I don't think that with 12 patients I can say, don't send me anyone who's monosomy, because obviously we are having some monosomy, peripheral monosomy have follicles. Don't send me anyone with a low AMH. I'm not ready to say that. I wish the Europeans would give that granular data so that we could start sort of deciding who can benefit from this and who can't. And in a few years, I'm hoping to maybe be able to give those recommendations, but at this stage, we're being agnostic about that.
In the interest of time, I am going to move on to our next session. Sorry. Thank you so much. That was such a great talk.